So this is a simulated trainee task assessing communication with colleagues, patient safety, and applied clinical knowledge. You are the ST5 in the gynecology clinic today. You are about to see Sarah, ST1, who wants to know more about how she can insert Mirena intrauterine system. You have 10 minutes in which you are requested to teach her and support her ongoing training. So another teaching station about Mirena insertion. So again, as any teaching station, introduce yourself by name and role. Um, Confirm the aim of meeting and welcome her to the department. Ask how's everything going so far to like screen for bullying or any problems, and offer your help and support, like if she needs any help at any time, she needs to come, and don't hesitate to come and contact you at any point, or any of other colleagues if she wants. Okay, and you confirm that she is the one who wants to know more about Mirena coil insertion. Is that right? And why she wants to learn about it. Then appreciate her interest, and then you give her the agenda. So we are going to talk about indication, contraindication, complications or risks of insertion, and I'm going to teach you the technique of Mirena coil insertion and how to follow up the patient after that. Okay. Okay, so first of all, what is Mirena insertion? You can ask her if she has any idea about Mirena coil. What is Mirena coil? Sometimes she may know, sometimes no, but yeah, you can just ask her. So Mirena coil is an intrauterine device which releases progesterone. Uh, the type of progesterone inside is levonorgestrel, and the coil contains 52 milligrams of levonorgestrel, and it releases every day 20 microgram. Okay, so the total amount is 52 milligram, and it releases daily 20 microgram. So why we need to insert Mirena coil, or what are the indications? First of all, it's one of the hormonal contraception, and is not only a hormonal method, it can act as a mechanical and hormonal combined method. So it's really highly effective contraception method. Can be used for 5 years, so the woman doesn't need to remember to take pills, or to miss to have any problem of missing pill or anything like that. So once inserted, it can last for 5 years. So it is more suitable for the patient who have a long-term plan for birth spacing. And since it is only releasing progesterone, it is considered as a progesterone-only contraception, so it is suitable for the patient who is contraindicated to take any estrogen method, like breastfeeding, like the patient who had a previous obstetric cholestasis, for example, or any patient with liver condition, any patient with previous coagulation or VTE risks, like that. Okay, so the mechanism of action as a contraception, it can be by thinning of the lining of the womb, of the uterus, under the effect of progesterone, making the environment of the endometrium unsuitable to keep the pregnancy in. That's one of the mechanisms. The second mechanism is also under the effect of progesterone. It can cause severe thickening of the cervical mucus, and that decrease the permeability of the mucus to pass the sperm through it. Okay, it also reduce ovulation or inhibit ovulation. Okay, and it also reduce the peristaltic movements of the fallopian tubes, so it will not allow the transmission of the embryo, even if it is fertilized. Okay, so it's a combined mechanism, and that's why it's very highly effective. So that is the first indication here, is the contraception. The second indication, it can be a treatment of heavy menstrual bleeding. So when a patient in a childbearing period comes to you with a heavy menstrual bleeding, and she tried medications from her GP like tranexamic acid, mefenamic acid, and it didn't help her, when she is not planning for a baby at the moment, the first line of treatment is to put for her a Mirena coil. Okay, so that's one of the indication, and it's one of one of the strongest indication for Mirena coil, because it reduces the bleeding, because it causes thinning of the endometrium. But we need to notify the woman that it has to take some time to build up the hormone level in your blood. So you may notice some spotting or irregularity or heavy bleeding even in the first few months, like 3 to 4 months. And after that, if you still remain with your symptom, then we like, if 6 months passed and there is no improvement in your heavy periods, then we need to take another treatment. Okay. One of the indication of Mirena coil is to treat endometrial hyperplasia without atipia. It is the first line, and it causes regression of this hyperplasia. Sometimes if the patient has even atipia with hyperplasia, however, this is not the first line of treatment, but in a specific situation, when the patient is unsuitable for surgery or unfit for surgery, or the patient is wishing fertility and we need to do some regression of the disease and have a trial with Mirena coil, so we can use it. So endometrial hyperplasia is considered one of the indication of the Mirena coil. Without atipia is the first line. With atipia is not the first line, but it can be inserted in a specific situation. It can be also used as like one of the HRT or hormone replacement therapy, when the patient is using estrogen patches, and we can insert a Mirena coil for her to counteract the estrogen and to avoid the harmful effect of estrogen in her uterus. So that can be used as a kind of hormone replacement therapy in postmenopausal symptoms. And also you need to know about if we use it for that reason, we need to limit the duration to 4 years instead of 5 years. One of the indication also is premenstrual tension syndrome. As you know, that it is one of the lines of treatment. When the first line failed, we can insert a Mirena coil and put also an estrogen patch. So it can be one of the treatments of premenstrual tension syndrome. So roughly these are most of the indications of Mirena coil. We need to know what are the contraindications. First of all, pregnancy. We can't insert a coil in a pregnant lady. So how to prove or how to confirm that the patient is not pregnant? First of all, we need to take a very good gynae history from the patient, confirm her last menstrual period, and if there any chance of pregnancy, we need to take a pregnancy test, urine pregnancy test on the same day. Okay. And the second contraindication, if the patient is having active pelvic infection, like if she's having like PID, or she's having a sexually transmitted infection, or any other infection is not treated and it is there actively, we need to treat the infection first, because otherwise we will push the infection to be intrauterine, and this may affect her future fertility. One of the contraindication is if the patient herself has a previous history or current breast cancer, is if the patient has a breast cancer, she can't use any hormonal contraception at all. So that's one of the contraindication. Another contraindication, if the patient is having something which may distort the uterine cavity, like if she has large fibroid, and especially if it is submucous, is not because anything rather than the coil may be displaced. Like if the patient has a large fibroid intracavitary and we inserted the coil, usually the coil will be not in the proper position and maybe failure will happen. Okay, so anything distorting the cavity. Uh, Another contraindication, if the patient, for example, having a cancer cervix, because cervical growth or cervical distortion that may cause, first of all, bleeding on touch, like when you hold the cervix and when you pass the coil through the cervix, it will bleed, and it may cause also like distortion of the shape of the cervical canal and increase the risk of perforation as well. And you know, if the patient is having cancer, is not recommended to use any hormonal method as well. One of the contraindication, if the patient has undiagnosed uterine bleeding, because we need to exclude cancer before inserting a Mirena. So if the patient, for example, coming with postmenopausal bleeding and we still don't know if this is just an endometrial hyperplasia or endometrial cancer, we can't put the Mirena and leave it. We need to take the sample first, and then if it is excluded or diagnosed for the cause, then we can insert the Mirena. And the last contraindication, for any patient, if she is allergic to any of the components, we can't insert that coil. Okay, so these are the contraindications. Coming for the complication or the possible risks. So we need to inform and explain to the patient everything about all the possible risks. First of all, she may have or she may experience some crampy pain, which may be like a period cramps. And we need to reassure the patient that it will go by its own within the first 24 hours. But if it is too much uncomfortable for you, you can use paracetamol and have some rest. Okay. Second thing, bleeding. So with insertion of anything inside the uterus, she may experience some spotting. The bleeding may be prolonged a little bit because we just inserted the coil. So we need to tell her that she may experience some irregular bleeding for the first couple of months after the insertion, and later on either her periods will become much reduced or completely amenorrhea. Okay. The risk of infection is still there. Sometimes the patient may have active infection, but it is undiagnosed and she doesn't have any symptoms, and suddenly when we insert the coil, we will introduce this infection inside. So it is recommended, if possible, to take some swabs and to exclude infection before insertion of any coil. One of the complications for anything that may be introduced inside the uterus is the uterine perforation. So we can tell the patient that sometimes making a hole in your womb can happen, and it can be very simple. If we suspect that, we will stop the procedure. We may need to take the coil out again, and you may need to stay just under observation for 24 hours. However, if the hole is too much big, or you actively bleeding or deteriorating, we may need to do a keyhole surgery to repair this hole. There is a risk of spontaneous expulsion with any coil, so we need to tell the patient sometimes you may expel the coil without any reason. There is a risk of failure because no contraceptive method is 100% effective. So there is a very minimal risk of failure, and if it fails, and pregnancy happen, most probably this pregnancy will be an ectopic one. So we need to notify the patient about this issue. Um, that's for the coil itself. What about the progesterone hormone? It releases progesterone. However, if it is even in a small amount, but it can cause some mood swings and vaginal dryness. So these are some of the complications of Mirena insertion. Why we need to know the specific technique of insertion of Mirena? We need to know well the proper technique of Mirena insertion, because it is once it is released from its tube or its sheath, it can't be reloaded. We will discard it to the pen if it is not correctly inserted. So you need to know well how we insert the Mirena coil inside, because it can't be reloaded again. Once it is released from the sheath, that's it. Okay? So there are some prerequisites we need to do it before insertion. So first of all, we need to explain to the patient about what is the procedure will involve, and take her consent. The consent will be a verbal one, because we are doing it without any anesthesia, and it is in the clinic. However, if the patient is too much uncomfortable, like sometimes she may have cervical stenosis, or she can't tolerate the speculum or anything like that, so she may request to insert Mirena coil under anesthesia. In that situation, we may need to take a written informed consent. Okay, so first you explain the procedure, take the consent. We can do some WHO checklist. We call it LOCSIPS. We will like yourself and the nurse do it together and sign it. Just confirm. This checklist can confirm, like, patient allergies, um, what is the if the procedure is done without any complication. Like, some checklist can be signed, and ask the patient to empty her bladder, and then she will lie down in lithotomy position. We put the speculum examination as usual. We'll hold the cervix with a tenaculum, and we will measure the uterus or the uterine length with a sound after the bimanual examination and confirming the direction of the uterus. So when we sound the uterus, we need to know really how to insert Mirena. And after insertion, uh, inside the package, there is a patient information leaflet. Inside the package of Mirena coil itself, there is a patient information leaflet. You give it to the patient. You tell her, this is information leaflets for you. You can read it as you wish. And there is a specific card inside the package as well. You write the name of the patient, the date of insertion, and the last date of removal, because the patient may forgot about the date of insertion. She has to keep this card for her records. So you write, sign it, and give it to the patient. Okay? And there is you have to record the number of the there is the slot number of the coil itself in the patient note. Okay. Now I'm going to show you what is the technique for Mirena coil insertion, and that's how to teach your colleague. And after that, you ask your colleague if he has any question, and you offer him that I'm going to give you some videos, usually on strategy, to teach you how to on strategy or YouTube to teach you how to insert a Mirena coil. And next time, if you want, we can ask the patient, and you can attend with me, and we will insert it together. Okay. Okay, so let's see how we will insert the Mirena. So when we open the package, we will have the Mirena coil as we see. So we have this part is called the flange. We can move it up and down according to the sound measurements. And here, as you can see, the arms coming out, you can't touch them like that. When you insert the coil, it has been untouched technique. And the trick here is the slider. That is how we insert the coil. So if you push it further to this point, this will bring the arms inside this tube. And if you move this slider backward to here, that will release the whole coil outside the tube. Previously there were threads coming from this point, but there is no more threads coming in the new version. So again, when you measure the sound of the uterus, you adjust this flange to the measurements and then move the slider forward like that. So this will bring the arms inside the tube like that. Then insert it through the cervical canal as usual, and then once you reach the fundus, we need to release the arms. So you can take the whole tube backward by 1 centimeter to give a space to the arms to come out, and then take it to the original point till this mark. So as you can see, the arm is now released. Then you can again push it to the fundus, and then now we need to release the whole coil by taking the whole thing downward. As you can see, the whole coil came out of the tube, and once you have done that, you can't reload the coil again. Okay, so let's repeat that steps from the slider. So first here, and then release the arm by doing that and take it out from here. Okay, this part of the coil is the part which is containing hormone, and these threads can be trimmed after we insert the coil.